It's working. Yes. So, a session on economics. You know that our health system in France is going through a time of deficit, and in all congresses we're speaking of the sustainability of our health system from the economic point of view. So thank you to Florian and to this Congress for making way for such issues. I'm now giving the floor to Mr. Zambrowski, who's a teacher at Paris 5 and who's a doctor at Bichat. I was told to let you know that you had 20 minutes, and as I'm the moderator, it's my role to ensure everybody keeps up with schedule. Thank you to the organizers. Thank you to those who realized that at ASCO, not only this year, but the year before, there was one day, the first day, devoted to value what we contribute in terms of cancer treatment, and they devoted this year 2 days before the Congress on this topic. I thought it was quite a paradoxical topic, economic intelligence. That's what we learn maybe in schools of economics or during spy training. There's influence, there's reputation, there's things linked to information protection. All this has to do with economic intelligence. But I thought I should have a closer look, because if we look at things properly, we had to wait until October 2003 to set up an economic assessment commission in our country, as if before that we as GPs, as pharmacologists, we could have said that, well, this wasn't our problem, we didn't have to be involved. Sorry, I didn't mean October 2003. October 2013, says the speaker. So we have this commission within the High Authority for Health. But the context, well, we can't have information without data. Nevertheless, all players in the field, all investigators, find it difficult to include an economic section in their surveys. This is meaningless because we have patients that are cared for according to specific protocols, but in some other areas, it is essential, but still we don't do this. We have health insurance that is collecting information according to the feedback they get from establishments. They have huge amounts of data, and they're only starting to be made public by health insurance and regional health agencies. And they're using this to actually impose upon us decisions that they think relevant. So, due to the lack of reliable information, the decision of those who govern, who lead the system, are made according to ideological approaches. And our establishments, we as players, are economic partakers, but due to the lack of such data properly analyzed, the decisions taken are not appropriate, and this is steering without visibility. And I don't know whether you've already tried to drive through the mist when your lights can not show you the way beyond the 1 meter beyond. But it is extremely difficult. So the definition of the dictionary in terms of economic intelligence implies the health professionals, but not only. The public debate that should take place on this is necessary and has to be taking place on the basis of reliable facts and proven figures. The political choices that are being made for 2016 or the law on health should also be drafted following the collection of reliable information. They should be evidence-based. We have evidence-based therapy, and we should have evidence-based therapy on the basis of resource consumption, not only financial resources, of course, and there's also confidentiality issues, of course. Personal data is of no interest for the decision makers, but and therefore, secrecy has to be preserved. So the stakes, the economic stakes of cancer is nothing new. In 1975, a Canadian author said the medical techniques are becoming more and more expensive as they become more state-of-the-art. The rights of the individual to life is going to be weighed between cost, economic compulsory choices, resources, and diverse issues that we have to prioritize. In a context of limited resources, we have to have healthcare in line with the requirements of reality. Some people say that cancer care costs far too much, but we have to remind people that beyond the amounts that are involved, this represents 150,000 lives per year. 30% of death are due to malignant tumors or disease. So please keep in mind 30% of these deaths due to cancer. We have 2,000 billion worth of wealth created every year. A little more than 14% are devoted to health, and this represents 190 billion euros shared out, as you can see, for last year with paradoxical situations such as biology having less devoted to it than ambulances and health-related transportation. So urban legend says that drugs are bringing down our finances. This is completely wrong. What you have here in green has to do with drugs, and it is negative. It has been since 2007, so it's not the increase in pharmaceutical expenditure that is due to the burden of health expenses. It is due to an extension of life. But nevertheless, a drug has a negative impact on the growth of health expenses. You see that we have the health system covering more than 3/4 of the expenses in the health system, which means that most patients benefit from an exemption through what we call the moderating ticket in the French system, which means 12% of the population are in ALD, and these 7 million people do consume more than 60% of the global expenses, which is quite natural, but which means that we have 75% of the global expenses in health devoted to this. Now, as to the figures that were published in 2009 on the basis of the national insurance systems of the various for the various countries of the OECD, represents a little more than 7 billion euros. We have morbidity issues or productivity issues. That is, for instance, a patient that cannot work anymore or only partially or is deceased. We don't take into account the fact that all individuals that are considered to be unable to move around, not only he cannot produce wealth, but he doesn't trigger wealth production, because he doesn't consume, he doesn't use the transport, he doesn't go to theater or whatever, because this person is completely unable to do so. So restoring their quality of life is also about restoring their economic contribution. And we're speaking of informal care, the natural helpers, so to say, relatives and people around the patient. And you see that the figures are we're under assessing this. Here you see that France is at such a level that it is as if in 2009 each inhabitant had spent 110 euros per day, so that people, per year, to make sure that people who have cancer could resort to treatments, be hospitalized or else. And you see the difference with the United Kingdom or Germany. In Germany, hospitalization is much more costly. The way they care resorts more to ambulatory solutions. People get surgery. We don't have that many treatments that can be given to be taken at home. The German outcomes, nevertheless, are exactly the same as ours, and I'm not even speaking of the English people who are not properly looked after. So cancer represents 2.5 million patients, which is really important, with 350,000 new cases each year, as mentioned before the break. You see that it's almost the same expenses that we have for heart diseases you see that people are turning to antidepressants, according to our picture, and you see the amount of the amount it represents in billions. It is absolutely delirious, without even speaking of people stopping their work or going on health leave. Cancer represents 10% of the expenses of our health insurance system. Therefore, trying to make oncologists or services, hospitals who provide cancer patients with treatment, trying to make them feel guilty is caricatural. It's not at all such a burden for the whole system. Of course, most of expenses are linked to the active stage. If we have a look at the figures given by the health insurance system, we have an expenditure of 10,737 per patient, which represents 894 euros per month. And this, the minimum wage was 1,420 euros. This means that the caring for a cancer patient costs less than 2/3 of the minimum wage. So who would dare say this is expensive? Nevertheless, people keep repeating this. And it's meaningless anyway, because each patient, each cancer represents a different cost. Some are better surgically dealt with. Some other type of cancers are better treated through radiotherapy. The expense profile is completely different depending on the cancer. All this has been broadly studied. The case we have here is of an economist who, of course, didn't renew his contract, but is giving us extremely interesting figures having to do with cancer patient treatment and care. We've heard the issue of nutrition and the lack of budget in this field. So here you see we've had only for the past 2 years a proper medical economic assessment of access to the market, and the rating is 1, 2, or 3. Either the issue is extremely important, there are very few, the products, that is the ones that can be part of the list. The others are left aside. We have to become familiar with 2 key indicators that we can find in all type of assessments, but which we found difficult to opt for here in our country. A quality adjusted life year is the QUALY acronym. So this quality adjusted life year is about seeing whether the patient is gaining 1 year with a high quality of life or not. If you say 6 months but with the same exemplary life quality, we have the same figure of 0.8. If we only gained 5 months with a poor quality of life, we have 0.5. The quality indicator is quite difficult. But ICER is even worse. That's incremental cost effectiveness ratio, which is cost total of A minus cost total of B divided by efficiency A and efficiency B. So this is important when analyzing cost efficiency and cost usefulness ratio. When something costs more but has a lesser impact, we take it. When something is more expensive but has a greater impact, we have to see whether the difference in terms of impact is worth it. And when something costs less and has less impact, we wonder whether in some cases one should have a better use of resource, but never at the cost of the interest of the patient, but given the various factors, comorbidities and other factors specific to the patient, if which one should wonder whether impact could be as satisfactory using less resources. Here we have a reference that is 1 GDP divided by 66 million people that we are to gain 1 QUALY. So if we have a drug that is worth less than 30,000 euros to gain 1 QUALY, we go for it immediately. That's gold. If it's beyond more than 150,000 euros for 1 QUALY, we do as we did for Sovaldi. We discussed so much that the supplier of the product or of the service is bringing down his prices, because if collective authorities is spending so much for only 1 patient, this is going to be at the cost of other patients who cannot be treated then. So what are the costs that we have to take into consideration? Everything. I mean, the cost not only of drugs, but of medical resources in general, hospitalizations, consultations and how long they last, visits to doctors, trials, yes, at the laboratory, preventive or curative treatments, corticotherapy, for instance, analgesics. All this has to be added to the cost of the treatment. Yes, I know I've reached 18 minutes. Well, I have 2 additional minutes. That's nice. So the non-medical cost, transportation of the patient, support workers at home, and voluntary people supporting the patient, and costs linked to a loss in productivity. And please add these parameters in assessing your activity, both for the short term as well as for the long term. It's important to include this when assessing the cost of the patient. You have to include the time, the length of time the patient is actually being ill. Then there was the quality of life, but I'm not going to get back to this because I've got only very few minutes left. Well, there are many cases studied elsewhere. We have here a very specific case of a woman that's who's 31-year-old. And we see how she's going to be exposed to less complications. Her multiple myeloma can be, even though, I mean, it's the core issue, we have other approaches, ways, to approach the other aspects they can make her case in terms of economics lighter. Isabelle Loca here has a paper on patients going through chemotherapies in the United States, and it shows that patients who have thromboembolisms are cared for in one specific way in the United States. When there is relapse of these thromboembolisms, when avoided, this enables us to save a lot of money. So we know that everywhere in the world it is proven, except here, of course, that when you have support care, we end up being economically beneficiary. It's the same here for penofibril. We see that the incremental cost efficiency ratio is of $13,000, so far below the costs that I was mentioning earlier. That means it would be costly. That's why these treatments are adopted without any hesitation. So there's something that seems obvious here when we compare benefits and or profits and costs. When we look at the expenses, we have less hospitalizations, less consultation for ambulatory patients, also side effects that are much lesser. So this is a win-win situation, and there's not many such examples in medicines. So it is important to promote studies that bring together medical benefits, the medical benefits of support care for patients in terms of survival, complications, relapses, quality of life, nutrition. If patients do not do this, do not ask for this, nobody else is going to do. This is our business. Our leaders are not going to do this. They're going to wait to give us the proper means, to wait until we prove, we give them evidence of the economic feasibility of what we're suggesting. The burden of the care of patients cannot be based on accounting criteria or administrative criteria. They have to be based on clinical and ethical criteria. People have to be involved in the economic dimension of health issues. We have to have real-life studies. We have to show how reliable and how relevant support care is for collectivities in terms of economics. Thank you for your attention.
Merci beaucoup, Monsieur Zambrowski.
Many thanks, Mr. Zambrowski. Let me get the discussion started. As a healthcare economist, I wholeheartedly agree with you. Medical and economic analyses. Well, that's a new thing in France in terms of setting prices for drugs. In a hospital setting, they've been around for longer. But you and I have both been working in hospital settings, and so we know about that. In terms of medical economic assessment in connection with support care, in your opinion, what are the current obstacles to such medical and economic assessments for support care? And should such assessments be carried out, what we do it for? Who would be interested? And then we have a panel of experts here. So what would you do? How would you convince these people to carry out medical and economic assessments for support care? Well, they were kind enough to invite me and invite you to discuss it, and so I will accept the invitation. In the very first edition of Florence Côté's publication, there's a study that says that over the first 2 years of a specialized unit, pain drops by 31%, palliative care by 10%, pain by 10%, etc., etc. So maybe that was not the initial plan, but they explained the ins and outs. Followed up between early 2011 until the end 2012. So that was in the Middle Ages. It's quite recent. So when they ask us to create a second position for a nutritionist to help Mr. Uzi with his job, they tell him, please prove to us that it makes sense, not just clinically speaking, but also cost effectively. So the rationale has been reversed. Now we only spend if the hospital gets to make money off it. So in the next study, this remarkable unit, which obtains excellent clinical results, which benefit the patient, we need economic. The problem is that they have to factor in economic concerns. And so say there's a dissertation about the clinical benefit, and of course the clinical benefit is a gradual prevalence in our country. So yes, it's important, but there's also economic considerations. There's no such thing as win-win situations, generally speaking, but here, yes, it's good for the patient, it's good for the community, and every time we try to demonstrate it, in every single time we demonstrated it, but we haven't done it properly back home in France. So, call to arms, people. Okay, getting back to the first thing you said about economic intelligence. You said how hard it is to collect economic intelligence. I agree with you completely, and also how difficult it is to disseminate information. Do you believe that Marisol Touraine, the healthcare minister's our plan will make things better in terms of providing better access to economic information? The economic intelligence is out there. Unfortunately, it's very hush-hush. Well, the current legislation falls far short of what is necessary. It's better than nothing. It's the beginning. It's the beginning of an embryonic start. I don't believe in this legislation, to be honest. I think it's just smoke and mirrors. But it is true that data is becoming available coming from the healthcare system, because the healthcare system has to realize that it is important. It is important. It is in their interest to release anonymous healthcare data. Or we have a healthcare system, but they focus on disease and not health. So we're flying by the seat of our pants, so to speak. So it would be in the interest of the HAS, the French top healthcare authority. Yes, unfortunately, it is not yet possible to release the information. It's ridiculous. They tell us they collect data. We collect data as well. We have our own data at our own scale. It is patchy. But medical and pharmacoeconomic studies are generally published in excellent publications, and also in the proceedings of various medical conventions. But in oncology congresses, we had to wait until last year before ASCO decided that this issue, because of soaring costs, that this issue is an obstacle to providing care. So maybe they have an agenda, I don't know. But it was banned. It was banned, and nobody talked about it. Nobody had a soapbox. So like it or not, we need to answer this problem. We need to collect data. We need economic information, and we need to insist so that public authorities will give us that information. So there should be an amendment to the law. And if nobody drives that amendment, if we leave it in the hands of the College of Healthcare Economists, I don't think we're going to go very far. Okay. With immuno-oncology molecules, that's a tidal wave we should expect in terms of efficacy, but also from a cost-effective point of view, because we're switching back from personalized medicine to large-scale mass spectrum medicine, considering the wide range of indications these new molecules will have. Do you think that this will promote access to and taking into account economic data? My answer would be I wish that would happen. Unfortunately, this may cause an intellectual tidal wave, an intellectual tsunami. There may be an imperious need. I'm not talking about industry, but say caregivers working together with patients and patient groups. Say one day they decide to advertise and they buy a centerfold in the Figaro magazine or the Economist. It has to be done properly, not on the basis of adversarial negotiations taking place in the dark of night. No. That day, maybe something will happen. But once again, that is our problem. We as doctors, we as physicians and pharmacists, we are dealing with the patients. It's our problem, we caregivers in the broad sense of the word. It's also a problem for patient groups. They have yet to fully appreciate the problem because of these smoke and mirrors, because of the cosmetic measures, the reality of the problem is being swept under the rug. And this is a clear and present danger. Let's turn to the audience. Any questions?
We have made a big mistake in medicine, worse in the United States than in Europe, but the same problem, of when we have cost effectiveness defined as an increment of life gained, we have not followed that before the recent molecules. So we have never followed cost effectiveness for drugs that do produce some cost effectiveness. And when we look at supportive care, we don't necessarily require or need cost effectiveness, that is, years of life gained. We're trying to have a cost benefit, but not necessarily cost effectiveness. So if we have not followed it for life gain where we can measure it, why do we expect that we will follow it otherwise? And so that's my comment. And so I think that we've been highly unsuccessful with looking at economics. And the reason is obvious, because there are people with an agenda to keep the cost of drugs as high as it could be in a regulated market where you do not have competition as you might with automobiles. So I've not seen a country that controls this well. And I also fear that since drugs cost 2 or 3 times as much in the United States and more in Japan than they do in Europe, that these have an effect on European costs as well. So
I certainly agree with you, but the thing is, I say it in French, non seulement vous avez raison,
Not only are you right, kind sir, but cost efficacy studies only look at the cost of acquisition, how much it costs to buy the product, not the cost of the disease.
c'est à l'intérieur d'un calcul global.
It is part of a global calculation that takes into account the global patient cost. Only then can we really appreciate and measure the benefit of adding a certain agent to the patient's therapeutic protocol. And what is true for one agent is also true for a surgical procedure or a course of chemo or radiation therapy, etc., etc. Unfortunately, not only these studies, whether real-life studies or whether looking at all of the resources mobilized, these studies aren't being done in the US, they're not being done in Europe. And they're barely emerging as an imperious need. I was talking about ASCO earlier. This was said by a number of ASCO participants, both from the US and from Europe, as well as other regions of the world, other regions, developed regions of the world where the problem has emerged. It is an imperative that our authorities engage in a discussion, not based on the cost of acquisition, the cost of buying 20 milligrams of a particular substance or maybe 20 mils of a particular solute, but what is the global impact on the patient cost for the paying authority? How much would it cost to introduce this new way, this new management method? In terms of the total cost, unless we have clear visibility, whether with regard to the current cycle or over a lifetime basis, that is the global patient cost, once again, we are flying by the seat of our pants. And this justifies the new modalities proposed by some, the new arrangements for paying for these products, which is based on profit. Assuming you're sure that this product was properly prescribed and properly administered. Because we can't guilt trip industry if the product was prescribed off-label, whether officially or rightly, let alone if the patient did not reserve the treatment, did not take the drug. So there are other arrangements being considered. They are based on the outcome, and we're going to pay for a global management method. I know it's very complicated, but that's the way forward.
I agree with you that the many points that you make of the many different costs that are involved, including missed work and all sorts of things, are important. However, the cost of many of the new pharmaceuticals over the last decade overwhelm all other costs, especially when a treatment is not curative. So we have drugs that cost $500,000 a year and prolong life a median of 3 months. So as was calculated at ASCO, over $1 million per year of life gained. These overwhelm all the other costs. So I think it is easy to present the case to say, forget all the other costs. If you just look at that acquisition cost, it really is the driver. Now, that's not true for a drug that costs 10,000 euros per year.
Très rapide la réponse.
Je pense que les
Please keep the answer short. I believe that the global cost should always be considered because there are always surprises. For example, you need to factor in the transport cost. If the cost of transport is 100 euros, and multiply that by 100, that's 10,000. So, what is realistic for a society? How much can our society withstand, and to what extent can we discuss prices with industry based on what they think they're owed, based on what they think they're entitled to? Thank you very much. I suggest you continue this discussion during the break. Many thanks for taking part in this session.